All right, guys, welcome back to Underground Science. In this video, we'll be talking about pulmonary embolism. Okay, so let's go and get started. So what is a pulmonary embolism? So a pulmonary embolism is when a clot, right, breaks off the venous system and lodges in your pulmonary arteries, right? So let's say we had a vein here, right? This can be the iliac vein, it could be a popliteal vein, it can be a femoral vein, right? And what happens is, right, if, and we'll talk about reasons why this happens and Virchow's triad and all that. But when a clot forms in these veins, it can dislodge, okay, and then travel all the way up. Because where do veins go, right? They dump into the right side of the heart, so the right heart. From the right heart, they go to your pulmonary artery, right? They go to the pulmonary artery and then through your pulmonary vasculature, right? And then go all, and then and then that blood goes to your right side of your heart or to your left side of your heart, right? So your left atrium, then your left ventricle, and then to your systemic circulation, right? As we know, right? That's the basic blood flow through your lungs or through your heart and through your lungs. So that's how a pulmonary embolism happens. You get a deep vein thrombosis. So that means thrombosis, so clot, in a deep vein, like your femoral vein, like your iliac vein, like your popliteal vein. And that clot can break off and then travel as an emboli or as an embolus and then lodge into your pulmonary artery, for example, leading to pulmonary embolism. So what symptoms can you expect, right? You may have heard this, right? So some symptoms are sudden onset shortness of breath. Okay. So if you see sudden onset shortness of breath, right? Along with that, you can see certain things like pleuritic chest pain, right? So sudden onset chest pain, shortness of breath, cough, right? Cough, um, even like tachycardia, tachypnea, hemoptysis, so coughing up blood. Symptoms like these can clue you into thinking about a pulmonary embolism, right? So that's a quick intro to pulmonary embolism. So let's see what we have here. So as we said, right, a deep vein thrombosis from a deep vein, right, like your iliac vein, popliteal vein, femoral vein, can break off and lodge into your pulmonary artery, right? And that can lead to a pulmonary embolism. And so the next thing we need to talk about is how do the clots even form? Okay, and that's where we talk about Virchow's triad, which involves hypercoagulability, endothelial damage, and stasis. Right, that's the triad when we're talking about Virchow's triad, right? So that's how clots form. So let's talk about hypercoagulability, right? So there's many states in which you can be hypercoagulable, and we've already done videos on most of these conditions and most of these states, right? So for example, if you have for example factor 5 Leiden, right? This makes you hypercoagulable. How? Remember, we talked about factor 5 Leiden. We'll quickly state it here, but remember, we have thrombin, right, in our bloodstream. Thrombin can bind thrombomodulin, okay, on our endothelial lining. When thrombin binds thrombomodulin, right? Remember, thrombin's function changes, and what it can do is it can actually activate protein C, right? And when thrombin activates protein C, then protein C inhibits factors 5 and 8. But in factor 5 Leiden, protein C cannot bind and inactivate factor 5 anymore. Okay, because you get a mutation in the factor 5 gene, remember. So if protein C can't inactivate factor 5, you have more clotting factors, more clotting risk, hence a hypercoagulable state. Okay, so that's factor 5 Leiden. What if we talked about, we just made a video on this, but what about prothrombin 20210A, right? Remember here, right, this leads to an increased increase in levels of prothrombin in your blood, which means more thrombin formation, more fibrin clot formation, right? So more clotting, again, more hypercoagulable. What if you have a protein C deficiency, right? What if you have a protein C deficiency? Well, we just said, what does protein C do? It inhibits clotting factors. Like what? Like factors 5 and 8. If you're deficient in protein C, you have more factors 5 and 8 that can be activated, which means no brake on clotting, which means more clotting, therefore a hypercoagulable state. All right, what if you had an antithrombin 3 deficiency? Well, what's antithrombin 3? Remember, antithrombin 3 inhibits factors 2 and 10, even factors 9, 11, and 12. So if you're deficient in antithrombin 3, you can't inhibit clotting factors anymore, like factors 2, 9, 10, 11, 12, which means you have more clotting factors available to clot, hence a hypercoagulable state. And of course, if you're deficient in antithrombin 3, remember, we talked about heparin doesn't work properly because heparin works through activating antithrombin 3. So if you're deficient in antithrombin 3, heparin can't work properly. Okay, so that's another hypercoagulable state. What if we had antiphospholipid syndrome? Antiphospholipid syndrome, right? Remember, antiphospholipid syndrome, we said, can be primary, so you can see this by itself, or you can see this in certain conditions, like in lupus, right? SLE, because you can have certain antibodies, right, that bind to proteins that are bound to phospholipids, like lupus anticoagulant, okay, or anticardiolipin antibodies, or anti-beta 2 glycoprotein 1 antibodies, right? We talked about this in the antiphospholipid syndrome video. But we said that these antibodies, right, can increase the activation of platelets, which can lead to more clotting. So in antiphospholipid syndrome, you have a hypercoagulable state. All right. And then more things like, for example, if the patient's taking oral contraceptives, right? We know that increased estrogen, right, can increase the activation of clotting factors, which puts you again, at a hypercoagulable state. So there's many conditions, right, that can put you in a hypercoagulable state, which is one of the three main things that make up Virchow's triad. Okay, so if you have hypercoagulability, that puts you at a more increased risk of forming clots. Okay, like deep vein thrombosis, for example. So let's talk about stasis, right? The second part of Virchow's triad. So stasis, right, is basically what it says, right? So you have prolonged immobilization. Okay, so no muscle contraction, right? So no muscle contraction for a prolonged time, right? So for an increased amount of time. If you don't remember, when you contract your muscles, then you squeeze your veins, and that helps move blood to your veins and then helps move blood to your heart, right? So if you don't contract your muscles for a long time, you get venous pooling, okay? And if blood pools in your veins like that, right, and doesn't move, you increase your chance of clot formation, like deep vein thrombosis, for example. What if you have a long flight, right, where you don't move at all, or long car rides, right, where you don't move at all? Again, that's going to lead to venous pooling and increase your chances of forming clots in your veins, like deep vein thrombosis, for example. So that's stasis. If we talk about endothelial injury, right, which is another part of Virchow's triad, right? This can increase your chance of clots too. Okay, so for example, if you damage your vessels through surgery, right? For example, so if you have surgery and you have a lot of damage to your blood vessel lining, we know endothelial damage attracts platelets, which can lead to clot formation. Okay, what if you have severe trauma, for example, right? If you directly injure your endothelial lining, again, right, your vessel wall, this increases clot formation. All right, what if you have atherosclerosis, right? So if you have atherosclerosis and you have a lot of plaque formation, this plaque can rupture. And remember, this damage of the endothelial lining, which if you damage your endothelial lining, you can express tissue factor, which is factor 3, thromboplastin, right? And that can trigger clotting. So you have endothelial injury now that we talked about that can increase your chance of clot formation. So this is how clots can form, right? Any of these, right, increase your chance of clotting. So that's Virchow's triad. Virchow's triad increases your risk of clot formation, like deep vein thromboses. If you form a clot in your veins like this, it can dislodge and then go and lodge into your pulmonary vasculature, causing your pulmonary embolism symptoms like sudden shortness of breath, pleuritic chest pain, cough, hemoptysis, tachycardia, tachypnea, and so on. Okay, so now that we know that, right, let's move on and see what we have next. So let's talk about the clinical presentation and the findings we can see, right, which we already talked about too. So again, if a clot forms, right, in your pulmonary vasculature, you can get hemoptysis where you cough up blood, right? You can get sudden pleuritic chest pain, all right? And if you have enough inflammation of your pleural lining, this can lead to pleural effusion, okay? So if, for example, right, if we quickly drew a gross diagram, right? So as you guys know, I'm not good at drawing. So let's say you have your trachea there, and we get its branches, right? And eventually, we're going to get um, bronchioles, right? A little bronchiole like this. And eventually, we're going to have our alveoli, right? But what we have to actually, what we should have focused on is this. So let's say we have our, again, trachea, your bronchi, right? And then let's just draw our lungs. And what we're going to do, just for the purpose of understanding this, we're going to draw our lungs as a square right now, okay? So remember, we have pleura, right? And we have two layers. So we have our visceral pleura, which is attached directly to your lung tissue, right? So if we draw a visceral pleura like that, okay, in green, and then you have your parietal pleura, which is attached to structures like your diaphragm, for example, your mediastinum and your chest wall. Okay, so let's just draw that like this, right? We'll draw your parietal pleura like this, and then in between that we have our pleural space. Okay, so that's your parietal pleura in blue. Okay, again, that's attached, that lines your chest wall and your diaphragm and mediastinum. And your parietal pleura has pain fibers. Okay, so that's why you get pleuritic chest pain, but we'll talk about that right now. So let's say you have a pulmonary embolism and that clot is huge. Okay, if that clot is huge, you can cause it, or that can lead to infarction of your lung tissue, right? The reason being is, remember, your right side of the heart, okay, your right ventricle sends deoxygenated blood to your lungs, and then your lungs oxygenate it and send it to your left atrium, then from your left atrium to your left ventricle, from left ventricle to systemic circulation, right? Part of that systemic circulation, though, is the blood vessels that supply your lung tissue, not your pulmonary capillaries, your blood vessels that supply your lung tissue. Okay, so your lung tissue needs oxygen too, right? So if you're pumping out oxygenated blood from your left ventricle, right, that oxygenated blood will go to your blood vessels, supplying your lung tissue, right? Supplying your lung tissue. Okay, but if you have a pulmonary embolism, right here, a huge clot blocking off blood flow, so that very little oxygenated blood makes it back to your left ventricle, right? Your left atrium and your left ventricle. That means your left ventricle will be pumping out very poorly oxygenated blood. So if poorly oxygenated blood is going to your systemic circulation, part of that systemic circulation being blood vessels supplying your lung parenchyma, then you can get infarction of your lung tissue. So then if you get infarction of your lung tissue, right, that infarcted tissue can irritate your pleura, right, especially your parietal pleura. And if you get irritation of your parietal pleura, right, you have pain fibers that supply it, like your intercostal nerves, right? So then that can lead to pleuritic chest pain. And if you have enough irritation of your parietal pleura, that can lead to leakage, right, from local capillaries. Okay, so if you have irritation of your parietal pleura, we said that can lead to pleural inflammation and pleuritic pain, which makes sense, right? So every time you breathe in, for example, you would have chest pain, okay, pleuritic pain, because of course, if you're breathing in, you're expanding your lungs, and your pleura, right, surround your lungs. So if you expand your lungs, that would lead to pleuritic chest pain because your pleura surrounds your lungs, and your pleura is inflamed and irritated due to lung infarction in this example, right? And if you irritate your pleura, right, there's local capillaries, right, that can also respond to this irritation, vasodilate, and have capillary leakage. Okay, so you can have capillary leakage here. Okay, and that can leak fluid into your pleural space. If you have enough of this, right? If you have excess fluid leaking in, that can lead to a pleural effusion. Okay, so that's the basic mechanism of pleural effusion and pleuritic chest pain. All right, so let's see what we have next. So, of course, we talked about dyspnea, right? Sudden onset shortness of breath. We just talked about hemoptysis, pleuritic chest pain, pleural effusion, hypoxemia, of course, right? Because we just remember if there's a big clot in your pulmonary arteries, there's less oxygenated blood that's making it back to your left side of the heart, which means less oxygen and less oxygenated blood is being pumped into systemic circulation, leading to hypoxemia or low partial pressure of oxygen in your blood. Okay. If you have low oxygen in your blood, that can trigger a reflex, right? So your brainstem can send signals to your heart, right? To control, like your SA node, for example, to increase your heart rate. So you can see tachycardia. And low oxygen can also trigger your brainstem to send signals to your respiratory muscles so you breathe faster, so you see tachypnea, right? Increased respiratory rate, which it can actually lead to respiratory alkalosis, right? Because if you're hyperventilating, you're breathing off a lot of CO2, and we know that normally, right, CO2 can combine with water and form carbonic acid, and then we know carbonic acid can dissociate into hydrogen protons and bicarb. So technically, if you're breathing off a lot of CO2, that means you're breathing off an acidotic molecule, right? Because hydrogen protons are acidotic in nature. So if you're breathing off a lot of CO2, that means you're going to be more alkalotic. Okay. So that's why you see respiratory alkalosis. Now, if you have a massive pulmonary embolism to the point where you're getting no blood flow across, right, from your pulmonary artery and back into your left side of your heart, then that can lead to severe drop in blood pressure and sudden death, right? Because normally, if we see the right side of your heart, or your right ventricle, for example, right, sends blood through your pulmonary arteries and then it goes through your pulmonary capillaries, pulmonary veins, comes back to your left side of your heart, right? So if you have a small pulmonary embolism, sometimes you can have very minimal symptoms, right? If you have a small clot, that's not really blocking blood flow off, so you won't see any lung infarction in this, right? And you may see minimal symptoms. It may be silent. But if you have a big clot, right, a massive pulmonary embolism, now you completely block off blood flow. That means there's very little blood flow coming back to your left side of your heart. So very little blood flow is coming back to your left ventricle, right? Of course, it goes to your left atrium, then left ventricle, but there's very little blood flow coming to your left ventricle. If your left ventricle is barely pumping any blood out, you're going to reduce the amount of blood in your systemic circulation, which means massive reduction in blood pressure. So severe hypotension can occur. Okay. So hopefully that finding makes sense. Now, what was the other thing we wrote here? And then sudden death, of course, right? Because if you suddenly decrease perfusion to your tissues, right, like your brain being one of those tissues, your heart muscle, and so on, that can lead to sudden death. All right. So, so those are the main clinical features when talking about pulmonary embolism. All right. So again, if we just talked about something more specific here, and we already mentioned some of this too, when we're talking about pulmonary embolism, you can have a hemodynamically stable pulmonary embolism, but if you get a massive pulmonary embolism, you can have that becomes hemodynamically unstable. Okay. So hemodynamically stable pulmonary embolism would be a small clot, right, in your pulmonary arteries, which would lead to minimal symptoms. So you have a normal blood pressure and no shock-like symptoms, right? So there you start anticoagulation and you would consider things like heparin or direct oral anticoagulants, right? So we have a hemodynamically stable, right, pulmonary embolism where the clot's not that big. You're still getting blood flow across, right, across your pulmonary arteries into your lung vasculature, like your pulmonary capillaries and veins, and back to your left heart. You're getting adequate amount of blood pumped from your left heart to your systemic circulation. So your blood pressure is pretty normal, no shock-like symptoms. Okay, so that's a hemodynamically stable pulmonary embolism. In that case, because you still are getting clots, just not that big, you would still do anticoagulation, right? So you'd want to give things like heparin. Okay, remember heparin stimulates antithrombin 3, which inhibits factors 2 and 10. You can also give things, so remember heparin, right? Or direct oral anticoagulants like rivaroxaban or apixaban, which directly inhibits factor 10, right? So factor 10 inhibitors can be considered too. Even warfarin, right? But if you do warfarin, you just have to be careful for patients that are at a higher risk of forming clots. All right. Like, for example, if they have some sort of heart disease, or if they have some sort of clotting disorder, right? Like protein C deficiency, right? For example, or if they have a mechanical heart valve, right? They're at more increased risk of forming clots. So you'd want to do the heparin bridge with this, right? Which we talked about in a previous video. Because remember, when you give warfarin, because protein C has a lower half-life, protein C gets degraded faster. So when you give warfarin, you actually are in a prothrombotic state for the first few days, right? So you'd want to give heparin with warfarin so that you're not in a prothrombotic state, so that even if warfarin is causing a breakdown in protein C, right, faster than your relative coagulation factors, you can give heparin, right, with warfarin, which means that you can also, so that way you're going to be able to inhibit your clotting factors like factors 2 and 10, right? So that you're not in a prothrombotic state. And then once warfarin comes to full effect, you can take off heparin. Okay. But that's for patients who are at more risk of clotting because warfarin and like protein C deficiency, for example, that can increase your chances of warfarin-induced skin necrosis, right? So that's hemodynamically stable pulmonary embolism. But what if you have a massive pulmonary embolism, like we talked about, right? Where your right ventricle, so if you have your right ventricle here, then your pulmonary artery here, right? And you have a massive pulmonary embolism completely blocking off blood flow. Okay, so no blood flow is making it through your capillaries and veins, right? Your pulmonary capillaries and veins. Barely any blood flow is coming back to your right side of your heart, and eventually to your or left or to your left side of your heart. My apologies, right? So barely any blood flow is making it back to your left side of your heart. So there's barely any blood that's being pumped out of your left ventricle. That means you're going to have severe hypotension and shock, right? Severe hypotension and shock. So that's hemodynamically unstable. All right. And remember, if you have a massive pulmonary embolism here, right, in your pulmonary, if you have a massive pulmonary embolism in your pulmonary artery like this, imagine how hard your right ventricle is going to have to work to pump blood against this, right? So this can increase your right ventricle, the strain of your right ventricle. Okay, so you have an increased right heart strain too, and massive pulmonary embolisms. Okay, so that's something to keep in mind also. So that's hemodynamically stable versus unstable. Okay, so let's move on and see what we have next. So in terms of diagnosis, right, we can start by looking at D dimer. So if we look at D dimer, right, remember how do we get D dimer, right? So if you form a clot and then you have fibrin that cross links, right, to form a stable clot. And if you break that fibrin, right, that cross-linked fibrin, you get D-dimer as a product. All right, so that means if you have D-dimer in your blood, you're forming clots. That's an indication. So sure you're going to see an elevated D-dimer because you're forming clots, right? That's what pulmonary embolism is. And then if you would do like a CT pulmonary angiography, right, which is really good at seeing blood flow through your pulmonary vasculature, you would see filling defects, right? Because we have clots blocking proper blood flow. So of course that would make sense. You would see defects if you did a CT pulmonary angiography, okay? And then we would also see a VQ mismatch, right? Because you may be getting good ventilation, right? Good oxygen into your alveoli, right? So you're getting good ventilation, but then what happens is, remember, your circulation though is messed up, right? Because if this is your capillary, remember this, you have your pulmonary artery here, which eventually branches into capillaries, right? Pulmonary capillaries. This is your pulmonary artery. If you have a clot here, there's less blood flow, right, going to your pulmonary capillaries. So that's why your perfusion part of your VQ ratio is going to be messed up. So that's why you see a VQ mismatch, right? Because you're not getting enough perfusion through your pulmonary capillaries due to the pulmonary embolism, right? Due to the clot in the pulmonary arteries. So VQ mismatch should make sense too. And then of course, if you're getting low oxygen in your blood, right, because of this clot, you have less oxygen, less deoxygenated blood that's coming over to your lungs. So that means you have less blood getting oxygenated, right? Because you're not getting enough perfusion. So if you have less blood getting oxygenated, less oxygenated blood makes it to your left ventricle, and less oxygenated blood is pumped out of your left ventricle into your systemic circulation. So that means you get hypoxia, or you can get hypoxemia. And we know hypoxemia can trigger a reflex, right? So your brainstem can send signals to your respiratory muscles to breathe faster. So you see hyperventilation, and your sympathetic nervous system can get activated, which stimulates your sinoatrial node, remember, in your heart, which increases your heart rate. So you do see something like sinus tachycardia. You can see that in pulmonary embolism. Okay. Now, with that, something cool to know is you can also see an EKG change, which is called an S1Q3T3 finding. Okay, and that's when you see that, right? That can be another indication of a pulmonary embolism. Okay, but the main EKG finding would be, of course, sinus tachycardia. Now, what's S1Q3T3, right? Let's talk about that quickly before we move on. So let's talk about the S1 part of this name, right? So S1 is talking about the S wave in lead one, okay? And what you're going to see is a deep S wave in lead one. That's the S1 part of the pattern, right? So you can see a deep S wave. So if we're looking at this, right, we know this is your Q, R, and then you're going to see a deep S wave, okay? A deep S wave in lead one. Okay, so that's what the S1 part means. What about Q3, right? What about Q3? So we have S1, Q3, T3. What does Q3 mean? In lead three, right, you see a Q wave. Okay, so you would see a Q wave in lead three. All right, so that's what the Q3 means. And then the T3, right, means that in lead three, you're going to see an inverted T wave. So remember, you have your Q, R, S complex, right? And then normally you have a T wave like that. And of course we didn't draw the P wave here, but you do have normally you have a P wave, right? Which indicates atrial depolarization. And then your QRS is when your ventricles contract. And then your T wave is ventricular repolarization, right? But in pulmonary embolism, right, in the S1Q3T3 finding, in lead three, you see T wave inversion. Okay, so you can see something like that in lead three. Okay, and of course, in lead three, you would also see a Q wave too. Okay, so that's S1Q3T3. All right. So that's the EKG finding for that, for pulmonary embolism. Now, if you did an arterial blood gas, right? Again, we already explained you would see hypoxemia and hypocapnia. Why? Because of respiratory alkalosis. Remember, hyperventilation, you're breathing off CO2, and CO2 is acidotic in nature because it can combine with water, form carbonic acid, right? Then carbonic acid can dissociate into hydrogen protons and bicarb. So hydrogen protons, as we know, is acidotic in nature. So if you're breathing off CO2, you're breathing off an acidotic molecule, making you more alkalotic. So you can see respiratory alkalosis, and because you're breathing off CO2, you're decreasing your CO2 levels in your blood, which is called hypocapnia. Okay, so that's that. And then what if you looked at your B-type natriuretic peptide, okay, your BNP levels? What is B-type natriuretic peptide? When your ventricles are stretched, right, then your ventricles can actually release BNP. Okay. So if they're stretched, they release BNP. So if you have a pulmonary embolism, right, for example, your right ventricle, remember, pumps blood into your pulmonary artery. And if you have a huge embolism here, a huge clot, then of course your right ventricle is going to have a much harder time pumping blood against this clot. So you can have increased right ventricular strain, right? Which can make your right ventricle more stretched, right? Because of course, if you can't pump blood properly forward, right, you can have blood that backs up and stretches your right ventricle. And on top of that, you get right ventricular strain, right? Because you have to generate higher pressures now to pump blood across this huge clot, right? So if your right ventricle gets more strained and more stretched, it releases B-type natriuretic peptide. Okay. And so if you see that, that can indicate ventricular strain, right? So remember, when your ventricular myocytes are stretched and strained, they release B-type natriuretic peptide. Okay, and the hope of this is to basically reduce your systemic vascular resistance, right? Because when do we see B-type natriuretic peptide release, especially in things like congestive heart failure, right? Because remember, in congestive heart failure, if we do a short deviation here, your left ventricle, let's say, right, is not able to pump blood effectively anymore, right? So if your left ventricle can't pump blood effectively anymore, right, that can lead to congestive heart failure. Okay, that's what it is. So like, especially if we talk about heart failure with reduced ejection fraction, where your left ventricle cannot pump enough blood effectively anymore out into the systemic circulation. What does that mean? That means more blood stays in your left ventricle and can dilate your left ventricle, which means your left ventricular myocytes, right, can release B-type natriuretic peptide. So if you're getting if your heart's not able to pump blood out effectively anymore, then that means you get your heart, right? Blood can back up into your heart, and then you can get fluid overloaded. Okay. So the whole goal of B-type natriuretic peptide then would be for you to not be fluid overloaded and to reduce your systemic vascular resistance, right? So that's one thing B-type natriuretic peptide does, is actually causes vasodilation. So you can imagine if your left ventricle is having a hard time pump blood out into your systemic circulation, right? And then if B-type natriuretic peptide vasodilates your blood vessels, right, in your systemic circulation, your left ventricle will have an easier time pumping blood into a low pressure system. Okay, so that's the goal of vasodilation, to get more blood out of your heart. Now, another thing B-type natriuretic peptide does is it actually opposes angiotensin 2. What does angiotensin 2 do? It leads to the secretion of ADH and aldosterone, right? Both of these increases your blood volume, which means you get more fluid overloaded, and it's harder for your heart to pump blood out from your heart into your systemic circulation. Okay. Now, but specifically though, why would increasing your blood volume be bad in congestive heart failure patients? Well, remember the whole thing with congestive heart failure is your heart's not able to pump blood out effectively. So that means you have a higher blood volume in your heart, right? And then now on top of that, if you have a lot of ADH and a lot of aldosterone, you increase your blood volume a lot more, right? Which means more blood is going to return to your heart. Well, your heart's already having a hard time pumping blood out. And if you're returning more blood, right, to your heart, it's not going to make it better, right? You're just going to have more issues pumping that extra fluid, extra blood out, right, from your heart to your systemic circulation. So it's just going to perpetuate the problem, right? So you would want to if you opposed this angiotensin 2, right, and you decreased aldosterone, for example, then you decrease sodium and water reabsorption and you decrease your blood volume, therefore decreasing preload and decreasing fluid return to your heart, right? Therefore, your heart doesn't have that much of a harder time pumping all that extra blood out, right, into your systemic circulation. So that's why BNP is really good at what? Vasodilating, right? Decreasing systemic vascular resistance. So your heart can have an easier time pumping blood into a low pressure circuit, like your systemic vessels, right? If they're vasodilated. And BNP also um, promotes, right, sodium and water loss in your urine. Okay, so promotes sodium and water loss, right, in urine. That way, you decrease your blood volume, and you decrease blood amount of blood returning to your heart, which means you give your heart an easier time, right? So that it can properly pump so that it can try to properly pump enough blood out into your systemic circulation, so you don't overload your heart. So that's why your ventricles release BNP, okay? B-type natriuretic peptide. So coming back to this, right, it would make sense your right ventricle myocytes, right, can release BNP in response to a big pulmonary embolism like that. Because if you have a pulmonary embolism, your right ventricle cannot pump blood effectively through. So that means blood can back up and acutely stretch and dilate your right ventricle, and then of course this can lead to right heart strain, right? And then that leads to the release of BNP in the hopes of doing what we just said, reducing systemic vascular resistance, reducing blood volume. Okay, so BNP can be another indication of something wrong, right, with your heart, for example. And then, of course, we know that the more you increase right heart strain, this can lead to right heart failure. Okay. So again, BNP can be an indication of something's wrong with your heart, right? Your heart's trying to release BNP so that you can decrease your overall blood volume, right? So you can excrete more sodium and water in your urine. All right. So that's BNP. Okay. So hopefully talking about specific aspects like this, right, of the diagnosis, made sense and was helpful in just giving you an indication about pulmonary embolism. All right, so those are the main diagnosis features that we should look out for. And then, of course, if we did like an echocardiogram, right, then you can see your right ventricle dilated, right, and then you can also see a pulmonary embolism, whether that's not that big or a massive pulmonary embolism. Okay. And of course, we already talked about this, but remember the ABG, right? You would see a decreased PaO2, right? Because we talked about hypoxemia. You would see hypocapnia, all right, because of hyperventilation. And due to hyperventilation, you can see respiratory alkalosis. Okay. So hopefully all these findings make sense. So now that we talked about the main things, right, about pulmonary embolism in terms of diagnosis, clinical features, and the pathophysiology, let's talk about management, okay, or treatment. So of course, pulmonary embolism involves clots, right? So if it's not that big of a clot, right, to the point where you get mild symptoms, anticoagulation, of course, is considered like we talked about, like heparin or direct oral anticoagulants like apixaban or rivaroxaban or warfarin. But if you do warfarin, right, make sure you do the heparin bridge, especially if your patient is more prone to clot formation, right? So anticoagulation is definitely a good treatment. What if it's a massive pulmonary embolism, though, right? To the point where it's almost completely blocking off blood flow from your right ventricle and through your pulmonary artery, okay? If it's a massive blood clot, then consider things like a TPA, right? Like alteplase, for example. Because remember, you would want to quickly dissolve that clot and break that clot apart so that you can restore blood flow across the pulmonary artery so that you don't get massive infarction of your lung parenchyma, all right? And also, if you have a massive clot, you want to break that down quickly, not only because you don't want massive lung infarction, but also remember, if you're not getting any blood flow across your pulmonary artery, that means you're not getting much blood return in your left side of your heart, which means you won't get any blood pumped out into your systemic circulation, which can lead to massive hypotension and shock. Okay, so if it's a massive pulmonary embolism, you definitely want to consider thrombolytics. Okay, like alteplase, which is TPA. Remember, TPA, what is that? What does TPA do, right? It converts plasminogen into plasmin. And plasmin, as we know, does a lot of things, one of it being it cleaves fibrin, right? Fibrinogen and fibrinogen, okay? But as we know, because we talked about this in the previous videos, not only does it do that, but it also inhibits platelet aggregation, right? And then we also know that plasmin can cleave clotting factors. Okay. So that's why you would want to give plasmin because you want to break apart that fibrin clot. And remember, that's why you see D-dimer when you because if you have clots, right, that of course are present because that's what pulmonary embolism is. Those clots will eventually break down, and then the product of that D-dimer. Okay, but let's just focus on the fact that plasmin, right, breaks apart fibrin clots, and it can also break down fibrinogen, cleave clotting factors, and inhibit platelet aggregation. Okay, so that's why TPA is good, especially if you have a massive pulmonary embolism. However, consider the fact that you should consider other parts, right, of the patient's history. Like, for example, if they had recent surgery, right? So if they had recent surgery or they have a condition where they're prone to bleeding, right, then you can consider an embolectomy, okay, instead of TPA if TPA is contraindicated. Another cool treatment or another cool management, right, that I found was an inferior vena cava filter. Okay, that's actually pretty cool because like let's say, right, we have our inferior vena cava, okay, and we know our inferior vena cava is returning deoxygenated blood to your right side of your heart, right, your right heart. But remember, if we get a DVT, that DVT comes through your inferior vena cava to your right side of your heart, then goes to your pulmonary arteries and then causes a pulmonary embolism, right? So if you have an inferior vena cava filter, where you just basically have a filter here, right? So you have a filter here. So I'm gonna try to draw like a net, okay? If you have an inferior vena cava filter, so this is your inferior vena cava, right? Then the DVTs that are traveling up will get filtered out, right? And won't make it to your right side of your heart and will not make it to your pulmonary arteries, therefore will not cause a pulmonary embolism, right? So that's kind of cool, okay? So that's another management to keep in mind. All right. So, but that's basically pulmonary embolism. Okay. So hopefully this video wasn't too confusing or anything. Hopefully it helped a little bit. Thank you guys for watching and see you guys in my future videos.